morning, everyone. Welcome to TeleShadowing. We are live on YouTube. As always, feel free to ask questions in the chat box as we go along, and your questions will be addressed. Dr. Jill Rosenthal serves as Senior Vice President and Medical Officer at the Zenith Insurance Company. She is board certified in occupational and environmental medicine by the American Board of Preventive Medicine, and she earned her bachelor's from Duke University and her medical degree from the University of Illinois. In addition, Dr. Rosenthal completed a master's in public health and a master's in sociology at the University of Illinois, with a focus on safety, health, and also risk behaviors. She serves as a fellow of the American College of Occupational and Environmental Medicine, the ACOEM, and Dr. Rosenthal is a president of also served as president of ACOEM's Florida component. She was appointed by Florida Surgeon General to serve on the Florida Prescription Drug Monitoring Program Foundation Board of Directors and is a member of its executive committee. Dr. Rosenthal speaks regularly at conferences nationwide, and she shares her experience in employee health and also workplace safety. Prior to joining Zenith, Dr. Rosenthal has had several leadership positions, including area medical director for Concentron South Florida, has served as a medical director in different roles at General Motors, the Midwest Generation, and many others as well, including employee health departments, as well as two Johnson & Johnson companies, which I find amazing. She has also served as the medical director and infection control officer for the City of West Palm Beach's fire and police departments, and has acted as a physician advisor for the SBC Smart Disability Program, as well as for Broadspire, General Electric, and also Federal Occupational Health. So also, Dr. Rosenthal has also contributed to the World Trade Center Worker and Volunteer Screening Program, and she evaluates it. She evaluates patients from its conception since May 2010. And her really diverse background and ongoing dedication to occupational medicine is what makes Dr. Rosenthal such a respected leader and advocate for workplace wellness. And without further ado, I'd love Dr. Rosenthal to please take it away and share her amazing journey with us. Thank you.
Thank you so much. I really appreciate being here today with you all. And if you're sitting here saying occupational medicine, what is that? You are not alone. This is not a field that I even really knew about. And I'm going to take you through my little journey in occupational medicine and then describe it a little bit better. So I'm going to share my screen. Give me 1 second here. And give me 1 second.
Yep, we see the slides.
Yeah, the screen share. There we go. All right. So I was initially matched in anesthesia. I let me even take you back to when I was in your shoes as a second year med student and trying to figure out what I wanted to do. There were so many opportunities, so many options, and little did I know that I didn't even know all of them. So I was a dancer in a previous life, and I loved orthopedics. I loved orthopedic surgery. I liked physical medicine rehab, all of that type of sports medicine type of stuff. So I was initially thinking about orthopedics. And now this was when I was in med school, was what, over 30 years ago. But at the time, I was doing my rotation in surgery and I was with an orthopedic surgeon and I was hand boring a hole for an ACL graft. And I'm sweating, I'm in the OR and just sweating away. And the surgeon looks at me and literally says, if you were a man, I would have given you this. And he takes out this electric tool and drills the hole, the rest of it. And I thought, wow, that's really interesting. And instead of saying, well, I'm going to show you, I'm going to show you what I'm capable of doing, as I actually was quite defeated. And I said, you know what? I really like being in the OR though. So I like the OR. And I started talking to all the anesthesiologists. And the idea of incorporating pharmacology and pathology and helping someone to survive a surgical procedure was actually really interesting to me. So I started down the path of anesthesia. To do anesthesia, you had to do an internal medicine year, right? Your internship year in internal medicine. So here we go. So my next slide. And now you're thinking, what does a red Solo cup have to do with internal medicine or anesthesia or anything? Well, I'm in the emergency room rotating during my internal medicine internship before anesthesia, and I walk into a door that says employee health. And I just said, what are you all doing here? It was right off the ER. And is this something I should learn about? And and then I look at the wall and I said, and why do you have a picture of a red Solo cup on the wall? So this literally was a picture on the wall in employee health. And the answer was, well, we take care of the people who work at the Solo cup factory. And I was like, wait, what do you mean? Well, this isn't what I'm used to. I'm used to having a clinic and patients come in and they're like, no. We have a clinic on site at the Solo Cup factory, and we try to prevent injuries from happening and then taking care of people when injuries do happen. And at that moment, I knew when I was asking for more information that resonated with me. So in undergrad, I had done a certificate program in the interaction between the biological, the psychological, and the sociological, which was new back then. To you all, it's probably old hat, but back then it was a little different. And so I was looking at it from, wait a second, I can look at preventing injuries. I can look at how this little mini society works at the factory and how this impacts the community and their families and these patients. I have to learn more. I have to learn more. So I called I'd matched at Hopkins, and I called Hopkins and I said, I don't think I'm coming for my anesthesia residency. That didn't go over so well, but at least I was communicating and telling them as soon as I knew. And I started looking at programs in occupational medicine and learning about the field. And I spoke with Linda Forst. Dr. Forst at the time was the head of the residency program at the University of Illinois in Chicago. And she was very welcoming and approachable and told me all about what she did. And she did a lot with migrant farm workers and keeping them healthy. She did have a position with their consulting group at the U of I that looked at companies and at the university itself. And her passion was, it was contagious. And so I immediately said, okay, this is definitely where I belong. This is a whole different track, but I'm going to do this. This is what I want to do. So I did a residency in occupational environmental medicine. Part of that is getting your master's in public health, so understanding some of the business aspects, the regulatory aspects, and also I was able to apply my interest in psychology, sociology, and biology at a time when that wasn't really the norm. So fast forward a little bit, I finished my residency and I had to do something kind of piecemeal, right? Like to figure out how to have a full-time job in occupational medicine, you need a lot of experience with corporations, with clinics, with different fields of medicine, because this occupational medicine, while also being the field that has the least burnout, which I think is amazing, the least burnout also has the most exposure to so many different fields of medicine. So if you think about occupational medicine and its role in workers' compensation, work comp injuries happen where they need treatment by every single specialty. So you might need a general surgeon for a hernia. You might need, an orthopedic surgeon for a shoulder or a knee or a hip or an ankle, name your body part. Cardiology, pulmonology, toxicology, dermatology. I like to say that at work, I've tried to reach out and create experts and access to experts in every ology that exists, because so many different fields of medicine touch workers' comp. Um, so as I'm trying to get my experience on the clinical side, I put together a lot of different, a lot of different roles and jobs, as you heard in the bio. So a lot of this was happening at the same time. So here, this is Western Healthcare, which is now called, at the time, I was the medical director for employee health at Evanston Northwestern Hospitals, which was 3 hospitals in the North Shore of Chicago, and going around from place to place, taking care of the nurses, the doctors, the techs, the housekeeping staff, everybody who made the hospital work and run. You think of needle sticks, but you also have to think about the people who are exposed to, like, unfortunately, like bodies get and body parts get cremated, right? And there are exposures associated with that. So how do you protect people when they're working in that environment? There was also a coal-fired power plant, and that has, you know, a lot of people in the environment would not be happy that these exist, but there are people who work there. There were people who worked there, and they deserved and needed to be protected. They're a vulnerable population who needed to have an advocate, and that's how I saw myself there. This this slide here is the University of Illinois at Chicago, and we took care of people on site. So the people who worked at the U of I, the people who worked at the U of I medical centers, but we also did some consulting gigs, if you will, at various places to provide smaller companies with access to a medical director, to prevention programs, and to pathways to treatment for their injured workers. And then here's for SBC, the linesmen and the lineswomen. This is a very actually dangerous job, and making sure that people are safe when they perform this duty is important. So that was my time in Chicago. And then after Chicago, I found myself in Atlanta. And in Atlanta, I had connected through ACOM, which is the American College of Occupational Environmental Medicine. I'm their current vice president, full disclosure, so I'm very big on ACOM. But I had met the medical director for the General Motors plant in Atlanta, in Doraville, Georgia. And he needed somebody when he wanted to go on vacation, or when he, had a doctor's appointment, to cover him. So I thought, you know what, that might be a really nice introduction to Atlanta and medicine in Atlanta, occupational medicine, and General Motors. So what I got to do at General Motors was amazing, because he ultimately moved up to Detroit, and I was able to take over as the medical director. We did daily rounds with the ergonomic specialist, who was one of the union guys. So it gave me this exposure to working with management, union, employees, face to face. We took care of their personal issues. We took care of their work injuries, vaccinations. And then when we did these rounds, we really connected with people to say, one, that we care about them, that they're heard, because they would tell us what their concerns were. They would tell us about a certain process. And while I couldn't change the process, I could advocate for them along with the union rep to the management at General Motors. So really impacting the plant workers, and the community. When working at General Motors, we made the minivan that nobody knows, the Uplander. It was a great little minivan. There was a Chevy one, a Buick one, and there were 3 different shifts. So there's a whole concept of health in shift work, and it exposed me to that, which is a very like a classic topic within occupational medicine, to really think about shift work, to think about people who don't work those 9-to-5 jobs. At the time, there was not a lot of remote work, right? It was a different era, if you will. But at the plant, they were just turning to technology and understanding how technology could help people without people feeling like they were going to completely lose their jobs. Then I moved home. So I'm from Miami, Florida, born and raised, and it was time for me to come home. So I moved down back to South Florida, and I had always said, and if anyone here has ever said this, the best lesson is never say never. I was like, I'll never work for Concentra. I don't know why I said this. I think I thought, oh, it's this, clinic and a doc in the box concept, which is horrible concept. We're physicians, we're clinicians, no matter where we're working, it's there, we're doing good work. But I started working, and Concentra opened me up to how clinics run, how to manage people, and also helped me to understand real time, real life occupational medicine. When they walk in the door, with the eye injury, with the laceration. What do I have to do? It was absolutely the best learning experience that I've had as an occupational medicine clinician on how to take care of my patients. It also taught me how to communicate best with companies who entrust their workers to you as a doctor to take care of them and ultimately to prevent them from getting hurt. So what do you do? So this patient comes in, you have to kind of interview them, right? We're asking what happened, but beyond understanding what happened to treat them, we're also trying to understand how did this happen so we can prevent it from happening again. And unfortunately, within workers' comp, you also have to understand, did this happen at work or did this happen outside of work and you don't have insurance and you're looking for someone else to pay it? It's like detective work. Most of the time, 97, 99% of the time, it's all legitimate. It's just you have to have that detective hat on in occupational medicine and workers' comp. In addition, you're looking at function. You're looking at what can they do, what can't they do? How do we get them back to a level of quality function, of quality life? And what can we do as doctors to get them there? And a lot of that is not only the treatment, but it's also attention to their job. So what do they do in their daily job that needs to be adjusted? So do they need work restrictions? Can they do their normal job? Is there another job that they can do while healing? Of course, if it's some infectious process and they're contagious, you do not want to expose other people to them. If they would be dangerous in any way to themselves or others, you don't want them doing that particular job. But really being like intentional and thoughtful about how you return someone to work or keep someone at work is part of occupational medicine. And I would call that the art of occupational medicine. There's a science, you have guidelines, you have population-based, evidence-based medicine guidelines that you follow. And then there's the art. And that's really understanding, well, let's say Joe can, I'm saying Joe can lift 25 pounds, no, up to 25 pounds. And they say, oh, Dr. Rosenthal, but this one job he has to do, he actually has to lift 27. And without that communication, he wouldn't be at work. But to me, I could say, okay, 27 is okay. If we were talking about a lot more, I don't think I'd be comfortable with that. But so that's where the communication amongst all the different stakeholders, and you've got the doctor, the patient, the employer, the insurance company, sometimes the lawyer. You've got a lot of different people playing a role in this state-regulated health system. Anyway, so that was Concentra. Concentra was a great time. That's where I connected with the West Palm Beach firefighters and police and took care of them. I was on call 24/7, 365. And it was the way I gave back to my community. In addition, I was the medical director for Piper Airlines, where I would have to go and look at their clinics. They were the people who made little planes up along the coast of Florida, and making sure that they knew that people were looking out for them, taking care of them. There was a nurse on site and overseeing the work that she did. And then the Johnson & Johnson companies. So one of those was Cordis, which makes stents, and one was microtyping, which is lab work. So the stent process proved to be a very interesting connection, and the J&J connection, because fast forward to now, I work for Zenith Insurance Company. I'm their chief medical officer. I'm in charge of medical management nationally for the company. And we have a parent company, Fairfax, and on the board of Fairfax is the ex-CEO of Johnson & Johnson. And when I was able to speak with him about some opportunities, having that past connection, having that understanding of his company and how he ran things was very helpful. Networking is huge in occupational medicine because you're not confined to a very specific, as you can tell, work site or type of work that you're doing in a way, or how you're using your occupational medicine knowledge or your environmental medicine knowledge. So networking is actually what took me from Concentra to Zenith. I had taken care of a certain school district, and the person who was in charge liked my work. And when Zenith said, hey, do you know of anyone who can be our Florida medical director? He said, I have a person in mind, and he gave them my name. And I interviewed and I said, I'll try this for a year. Well, I've been there 14 and a half years. I was their Florida medical director, and then I quickly advanced to all states outside of California. and I worked under the Chief Medical Officer, Dr. Ann Searcy, who has passed, but who sits on my shoulder all the time and reminds me of the importance of the evidence-based medicine, but also the importance of the art and the individuality of each case, and how you always have to look at the details and think critically and always remain true to why you went into medicine to begin with, which is to take care of people. My role at Zenith is quite varied. So as the chief medical officer now, I have a team of about 61 people. We have doctors, nurses, pharmacists in-house, billing and coding nurses. So I've had to get a deep understanding of billing and coding, although Dr. Claren is still the best at that, and I've learned from her. But we have those nurses, we have utilization review nurses. It's a big group of people who are just now starting to understand how technology can help us be more efficient. Why do I bring that up? I bring that up because while it said MSQM on the title slide, it should say MSQM candidate, just like student Dr. Chima is a candidate for her MD in 27. In 26, I will be hopefully getting that Master's of Science, and that is in health analytics. So I did my undergrad at Duke, as student Dr. Chima said, and I am back at Duke as a grad student, also as a parent, but that's a different story. But as a grad student, getting my master's in health analytics, understanding all of the data that we have as an insurance company has become my project. So how can I be a better chief medical officer? I need to look at how people are getting hurt, to whom we send patients. Are we sending people to the doctors who get them better, to the clinicians who get them better? Are we sending them to clinicians who understand the importance of return to work, who understand the nuances of workers' comp? The paperwork can get people down. They'll say, oh, there's so much paperwork. There's paperwork in everything, right? There's paperwork in Medicare, there's paperwork with regular insurance companies. But the thing about comp and the thing about occupational medicine is I feel like I'm constantly thinking and growing and learning. And with this new degree where I'm learning, health policy and econ and coding, like R and Python and all of that, is to try to say, okay, how do I use this new knowledge to make to make what we provide the patients a better experience and to get them back to health as soon as possible. Again, it's about function. Of course, we care about pain. Of course, we care about pain. Most important to me, though, is how does anything impact their ability to function, and not just function at work, but function in life. So if workers' comp is a state-run system. So every state's different, which makes it very interesting. I have this spreadsheet that I consult to say, okay, what can I do in this state? So let's take Florida, for instance. Someone gets hurt in Florida. I can send them to a specific doctor. I can say, Joe, you are going to Dr. Chima. And Joe will go to Dr. Chima, and Dr. Chima will take her history, will take a full history as you do them today, full physical exam based on the body part that's impacted and anything else relevant, and then say, okay, this is how I'm going to investigate this. This is how I'm going to treat this. And this is what you can do or not do at work. And that is all well and good, but then you cannot control pharmacy. So if Dr. Chima wants to prescribe a medication in Florida, workers' comp providers can dispense out of their own offices. So a lot of the practices have figured this out and said, I do great work. You're going to want to send to me. And by the way, I'm going to dispense diclofenac at $4,000 a month. I'm not kidding. And so they've become profit generators. So this allows me to say, okay, this is an issue. How do we solve for this issue? How do we make sure that, one, people even need the diclofenac to begin with? And number two, why would we be spending $4,000 on something that should cost $30? So I wear this hat of a business person. I wear the hat of a doctor. I wear the hat of a consumer. And you try to figure out, how to make everything fit so that never is quality of care compromised, but that you're engaged in fair business practices. So why do I do this? Oh, this is Duke. So this is where I'm doing the master's degree. I love Duke Chapel. It's gorgeous. um, this is my why. I think it's really important to understand your why. These are my 4 children. I have a 26-year-old, a 24-year-old, a 22-year-old, and a 20-year-old. And this is why I do what I do. I want to make the world a better place for them. I want the world to be healthier. I want the environment to be healthier. I want the economy to be healthy. I want these people to have a chance to be productive, happy individuals. So I think it's really important to always stand by your why and understand, not only do I have a passion for what I do, but I also have a passion for these people who keep me going. I think that's the end of the slideshow that I have for you, but there are other things that I do want to share with this group. I think when thinking about workers' comp, we get a little bit of a bad reputation or bad rap. People think, oh, well, you're not really a real doctor. No, I'm a real doctor. I'm an MD. I went to school. I did residency. I take care of people. I did clinical work for a very long time, and now I'm on the administrative side. But unfortunately, people don't understand that we did all that. A lot of times people think, oh, well, that's just where people go when they don't have any other option. Most of the people have chosen to do occupational medicine. I find that people say, oh, you're an occupational therapist. And I say, nope, occupational therapy is wonderful, but no, I am a physician. And it's interesting that I still have to explain myself in this field, but I'm happy to do it every time so that I can educate people on the field that I love so much. Yeah, it's taken me to places I never expected. I definitely did not expect to work for an insurance company. But for instance, the insurance company Fairfax that owns Zenith, or the parent company that owns Zenith, which is the insurance company, has a CEO, founder, board of director, the chairman of the board, Prem Watsa. Prem has involved me in some really interesting projects, including getting together the head of neurology and neurosurgery at Duke, with the India Institute of Technology in Madras, and some technology companies to try to figure out how we can better help people who have Parkinson's, how we can better help people recover from brain injuries, anoxic brain injuries. So we're getting together actually this month in Durham, North Carolina, to try to figure out how we can use the research that people are doing around the world in a collaborative fashion to make a difference. And again, this is something I never would have been able to be a part of, but for the path that led me through this occupational medicine journey. Where would I expect to go next? I think that my plan is to stay at Zenith. My plan is to continue to build a team that pays attention always to quality of care and never gets mired down in what people expect of insurance companies, which, the denials and all of that. We have an 87% approval rate on everything on first pass, everything that comes in. It usually makes sense because if you can control, the doctors and clinicians to whom the patients go, then you're picking quality doctors. You're picking doctors who know what they're doing, who make good decisions, and who do what's best for the patient. And I find that I spend most of my time, as we do, on the 13% or the 10% who try to do funny things like prescribing the diclofenac. I'll explain that even more. So this was topical diclofenac. So they expected the patient to apply the diclofenac liquid to all the affected body parts, 50 drops 4 times a day. Now, I can't imagine the compliance rate with that, not to mention that that doesn't seem to be the most efficient way to get diclofenac in the system, not to mention this person had no contraindications to taking it orally. So this was a pure profit generator. When I called the doctor about it and said, hey, listen, I'm not really sure that we can keep sending you patients because this doesn't really make sense. And oh no, they had a kidney stone in their past. And 20 years ago, they had a kidney stone. That's not a contraindication to diclofenac. And the next thing I knew, that particular doctor had made this patient MMI, which is maximum medical improvement, and discharged them with no impairment rating. So what in workers' comp, you have to say, is this person as better as much as they're going to be based on whatever their treatment regimen is today? And then if so, is there any kind of permanent impairment associated with it? So there's math involved, there's a lot of critical thinking, there's detective work. And again, it can be, the career can take you in so many different places. You can stay in clinical medicine. It's beautiful. You can be in academic medicine. You can be in research, in the military. I mean, we have friends on oil rigs in, the Middle East. We have people all over who we're connected with. And I say we being Dr. Claren also, who have such interesting roles at banks, the medical director at Delta Airlines, the medical director at Wells Fargo, all of these people who keep our businesses and the people who work at our businesses healthy across the world. Yeah, so I thank you so much. I don't really have that much more right now unless people have specific questions about comp in a specific state. There are 4 states, I think it's 4, that are monopolistic, so they take care of their own workers' comp, but all the rest we take care of. So happy to answer any questions that you might have. And yes, I was able to still be a very involved mom throughout the whole process, to the point that my kids still think I'm a helicopter parent. I'm thinking, how do you think that? But okay, I'll go with it. So
You're a superhero, Dr. Rosenthal. Honestly, like that's amazing. You wear many different hats, and it's so inspirational to hear about that and your incredible journey. We actually put together the questions that we received in the chat box on YouTube live stream and also the Zoom chat, and I'll be conducting the Q&A session. So first, I'm going to ask you a few questions. Well, I guess you mentioned workplace and work-life balance, so we can talk about that first. So how do you manage your work-life balance? How is that like in this specialty compared to other specialties you may know of?
yeah, so great question. Because as I mentioned, this is the field that has the least burnout of all specialties of medicine. Let's take that job I had at General Motors. So at General Motors, because there were 3 shifts, I said, what works for me, right? I really thought about myself and my family, and I said, okay, what I'd really like to do is I'd like to be able to take my kids to school. I'd like to be able to pick them up, and then I'd like to put them, get them ready for bed. And their dad was in his trauma surgery fellowship at Grady. So he wasn't there a lot, but we did have a woman who helped us. So it takes a village, right? It takes help. So pretty much all of my money that we were making went to her. But I would drop them off at school. I would go to General Motors. I would stay there the first shift, second shift, because there was crossover there. And then I was able to leave during the second shift, go pick up my kids, get them all set, and then show up for third shift. So it turned out I was the only doctor to ever be there for third shift. And we were able to identify issues and help people to become healthier on the third shift who were not so healthy. And accomplish some things from a health perspective and a wellness perspective that had never happened before, just because I was trying to make it work for me and my 4 kids. So, so that you just make it happen, right? Like you figure out what you need to do. And like, for instance, like now we're national. So I have a team that extends from Florida up to Northern California. So how do you create work-life balance when you've got a team like that? Well, I'd say, okay, I'm going to start later one day and work later. And one day I'm going to start earlier and end earlier. And so I may not be online for my team late in California on one day, but they can always call me. Being those days when I start later, how am I using my time in the morning to make my life feel like it's full? So I go to Pilates, I have my friends there, we all work, and it provides me with that balance that I need. On the weekends, making sure that I have my phone if there's be it Albuquerque, be it Chicago, and make sure that they know that we've got them, that they have somebody that's looking at everything, that this is not a typical insurance company, advocating for the best rehabs if they need one. We had a case where this is such an unfortunate case, but A young man was, they were laying cable at a sporting field, and it had rained the night before, and they were on a golf cart, and the supervisor's driving. The young man is on the back of the cart with a young woman, and the supervisor decides to do donuts. And upon doing these donuts, the young man, protecting the young woman next to him, ends up falling out of the cart and then gets run over by the cart. And um, umbilicus down, paraplegic immediately, and is in the hospital. And I go to see him, and I'm talking to his mom. And I mean, this kid had the most incredible character. Like he was the most unbelievable person to have the strength of being that he had, like the soul that he has is incredible, because he's like, okay, this is where I am now. What am I going to do about it? And how do I just make the best of this? Like, never did he feel bad for himself. I would have been in a whole different place. And I'm still amazed by this young man. Um, Anyway, so his mom was like, "Oh, we should just stay at the local rehab. They're advocating for this." Now, mind you, nowadays, when you've got all these hospital systems buying up doctors' practices, and the doctors are now contracted employees of the hospitals, a lot of them are required by contract to refer to that specific hospital's rehab, which may not be the best choice for a patient. So in states where we can direct care, we're like, okay, that's well and good, but if this were my child or me, I would be going here. And we talk about global centers of excellence. So this particular individual, it made sense for him to go to Shepherd Center in Atlanta. So he flew up there with his mom, got incredible care. He ended up in an exoskeleton and walking in the exoskeleton. It's the most touching video that we have in-house in the file, to see him walking and to know that this is why we do what we do. We had actually, I think we actually got him a car. We sent him back to school, and he's now working and living a full life as possible. And he's an amazing young man accomplishing great things. There was another patient who was a four caddy. A four caddy on a golf course is like the person who stands ahead of the golfer to kind of see where the ball ends up, where it goes from a better perspective. Well, he gets nailed in the head with a golf ball, and then loses all function on the left side of his body in Chicago. There was this is an interesting one. You think, why is this work related? There was a lawyer on a ski trip with his firm, and he had a horrible skiing accident, ended up with a significant brain injury. But because it was a firm sponsored event that he had to be at, it was work related, and he wasn't impaired in any way, because you have to look for that, because people shouldn't show up to work impaired. Um, we sent him to Craig Hospital in Denver. So like, you look for places that are global centers of excellence, and you send people to the one that makes the most sense for them, and watching people recover. And these are three stories of many. I mean, we've sent people to Tier in Houston, just had incredible results when we send them to these better places. And you might think, well, why would an insurance company do that? It's got to be less expensive at the rehab. That's local. And yeah, from a transactional perspective, it is, right? So the daily rate it is, but are they actually going to end up better? Are they going to ultimately have the best outcome? Are they going to be as functioning as possible, versus a global center of excellence? Well, the chances are that you'll get the better outcome at the global center of excellence. So that's the choice. So it's like an investment for the long term rather than the short daily perspective. It's like physical therapy that's $40. Well, if they have to do it 100 times and they're still not better, why not spend $100 12 times, right? So something like that. We look at it where you can't just look at the cost, you have to look at the quality. I know that was a lot of that was way more than what you asked me. I'm
It was
sorry.
perfect. Actually, it was very perfect because we had a follow-up question to that is about workplace compensation. And when an employee, I guess for context, this is what I learned in medical school, and you can correct me as well. When a patient is able to claim workplace compensation, the rest of their medical care is taken care of and paid for. So that is why they're able to be, sent to these like I guess quote unquote like a little bit better centers than they typically would if they were covered on their normal insurance provided by their employer.
Yeah, so when you have an accepted workers' compensation injury,
Hmm.
where what they were doing or their injury came out of the course and scope of their employment, they weren't impaired, and it's an authorized workers' comp injury, then they don't have a copay. They are not responsible for anything. There's no copay, there's no deductible. Now, people will say this term that drives me crazy because they'll say there's no skin in the game for them. And I
Hmm.
would counter with it is their skin that is in the game, right? It is their health, their wellness, their ability to function in life. And so they do have skin in the game, but they are not paying financially for that care. And anything that they like, if they need a ramp for their house or their house redone to accommodate their injury, like we have to do that, right? That's the right thing to do, and they need that. That's part of the coverage in most states. Um, with the van that we got him, probably, I mean, sometimes we go above and beyond. Like there was somebody who had a spinal cord injury, and we were able to get like a sperm sample to freeze so that he could potentially have children one day if he wanted to, right? Like that was to me amazing that we did that. That is not written in statute, right? But
Right.
that was like, we want to do this because that was his immediate concern. We're like, got it. If we can do it, we're doing it. Um, yeah, so there it's a different system in terms of payment and what the patient's responsible for care. So yes, that does give us a little bit of leeway to where we can send people versus like my own health insurance, right? Like my health insurance probably wouldn't cover me to go to Shirley Ryan Ability Lab. And I'd have to say, can I afford it? Can I not? And probably no, because I have those 4 kids who all went to out of state or private college. So no, I could not afford that. Um, but um, but but it's a good question. Yeah, it's certainly a good question because it's a different system that way now. There are certain states that have certain laws called hindrance doctrines. So hindrance would be like if they're not going to get better for if their orthopedic injury is not going to be get better because they're not controlling their diabetes, we might have to help them control their diabetes for a specific period of time to get them better from their work injury. So it might extend beyond the work diagnoses, and it could be their personal diagnoses that we have to take care of, again, depending on the state.
Got it. Okay, that makes sense. So it's very state specific. Every state has its own laws. So
Yeah, and like
yes.
causation, like
Hmm.
the causation is interesting because causation is not just medical causation, or excuse me, causation is like the medical side, but compensability is not just medical causation. Compensability deals with, again, that impairment concept. It's like, were they actually doing work that furthered the employer's job place? Were they fooling around? So there are lots of different things that go into compensability. So while we as physicians might say, well, why wasn't that covered? Because it was so clearly caused by this person hitting that person. Well, that person hit that other person because he's fooling around with his girlfriend and he came into his workplace, but that doesn't make it work related, right? And so you have to get more details that sometimes we as clinicians are not privy to when we see the patients in the office.
Got it. That's where the intersectionality with, law and medicine comes in and you work
Yeah.
with lawyers. All right. Well,
Yeah.
on the bright side, you don't have to struggle with, fighting with insurance companies for coverage as often as the normal physician would complain about. So then my question for you is, what are some of the biggest challenges that you face in your field?
So let me back up for a second. So
Mhm.
biggest challenge right now is access to care, 100% access to care in all of the different places in the country where people do work. But let me back up for a second. So um, while for the most part, everything gets approved from us, right? 87% on the first pass, and it's like 92% by the time you have a second pass. Doctors still need to like justify their decisions. And so the medical rationale for things does need to be provided, unfortunately, because of some bad players. So we can look at a case in California where there was a surgeon who was doing fusions on patients, would make up the rationale, like would make up the reason, and then put in counterfeit hardware made out of a garage into these people. So while they didn't start out disabled, they became disabled. Doctors who just order things by recipe, by rote, without like meaning. Or when I was a resident, I remember having med students rotate with me, and I was like, why do you want to order that lab? What will it change for you? Right? You're gonna send this person to an MRI. They're claustrophobic. They're gonna be nervous. Is that going to change anything for you? And if the answer is yes, then good. But if it's not, then why are you doing it? Right? It's the same thing. It's the same thing now. Like if a doctor wants to do something, like why are you choosing to do this? Sometimes it's not the right answer. We had a case one time where there was a trauma patient in Georgia. He was in like northern Georgia. He was from Florida. We had to get him home to Florida, but he was in the hospital, and I was looking at the case, and I just didn't feel like he was stable enough to be discharged from a like there was just something that stood out to me. It was just one of those things that didn't sound right. You know, sometimes you just have to go with your gut as a clinician. And so I called the trauma surgeon, and um he told me that I was challenging the entire system of trauma in our country, and how dare I disturb him while he drives his Porsche around, um, and that this patient is going to be discharged. And I was like, well, we're offering to keep them there, right? Like, we're not saying they need to be discharged early. We're saying like, are we sure that he's ready to go? Just knowing this guy after reading about him, and hangs up on me. It's like, okay, yelling at me, hangs up on me. You have to have a bit of a thick skin. And the poor guy gets discharged, doesn't even make it out of Georgia before he has to be readmitted because he like crashed. And it's not like, oh, I knew, like I always know, I don't always know anything, right? Like there are many times when I'm surprised, happily surprised, like, oh, good, like this worked as it was supposed to. This is great. But I'd rather question it and be wrong than not ask the question. And in this particular case, it just reminded me of why I have to keep asking the question.
Thank
Yeah.
you.
Okay. Now, my biggest challenge is access. So, a lot of people got burned out from medicine in general during COVID, and after COVID. And then you also have people in occupational medicine who are like aging out. They're retiring. They're leaving the field to retire, not because they're burned out. We're like, I'm going to go enjoy my life, right? I'm going to go enjoy the rest and enjoy this retirement period. And we don't have as many people in the pipeline to replace the people who are leaving. And so a lot of people don't truly understand comp and don't understand the nuances of occupational medicine. And so having access to people who truly get it, and who are willing to be detectives, and who are willing to also be kind and caring and advocate for the patients and the employers, right? Like in a way, it's both. You just want to advocate for the truth. That's I need to deal with the truth, and I don't care if it makes me sound naive. That is going to be the best way to take care of people. So access to people who get it, access to doctors in general, access to clinicians who understand all of the details of medicine. There are a lot of times right now when people's personal medical conditions are really impeding their health, right? Their ability to be healthy and well. And when you don't have a healthy population working, they're going to be more likely to get hurt. And we also have people who are rushing through things, and they're distracted by the phone, and I'm guilty as well. Walking and texting. I should not do that. People should not do that at work. People should not do that on the stairs, right? Again, like rushing through things, and people get hurt, and we need people who can take care of them, no matter if they're in Humboldt County, California, or Lakeland, Florida, or you know, I don't know, Boone, North Carolina, like wherever they are, they need care.
No, that's exactly right. And access to care, and also sometimes awareness that these things are available. And as I'm
Yeah.
really glad that my med school curriculum sort of like taught us, that occupational medicine exists, but a lot of people don't. Like I was reading an article the other day, like how medical students want to find the most work-life balance friendly profession, especially Gen Z, especially after the pandemic
Yeah.
and remote work. And no one's talking about preventive medicine or occupational medicine as being really everything that a medical student would dream about. And they don't really know that it's a reality. So thank you so much for sharing your journey and story. It's very exciting. Another question
Yeah,
that,
no, my,
of course, yeah, sorry, we have a lot of questions because
oh,
it's
good.
our
Oh, I
first time
can't see
here.
them, so I didn't know. Okay.
You're fine. How do you balance the interests of employees, and also the regulatory bodies in your work? Because I'm sure that they sometimes might have different interests.
Yeah, so the regulatory bodies for them, yeah, well, that's all that's all a balance, right? So you're trying to look at the balance of the patients, the doctors, the companies, the all the various stakeholders, the various interests, right? So the regulatory. I think what I try to do again is just look at the truth, right? Or what makes the most sense from a medical perspective, from a health quality, wellness quality perspective. So like if someone says that we need to prescribe, we can prescribe, um, I don't know what the right example is. Let me think for a second. Um, if we, I'm trying to think of a recent one. If we can, if we should prescribe like mushrooms to people for PTSD, right? Psilocybin. Okay, so uh, I want to look at, where's that coming from a regulatory perspective, and then how is it enacted, and is it safe? And so I try to look at the literature, looking at what population are we talking about, and let's say that it's the firefighters, let's say, then how are we going to make sure that they're not showing up to work impaired, right? Again, it's or marijuana, medical marijuana. Okay, how are we going to actually test for it to make sure people aren't impaired? That's part of the research I think needs to happen. Um, Now, alcohol we know was lobbied. Here's a great one, 0.08, right? That's not safe. Yeah, but we're impaired at 0.02. So, so the clinical kind of goes out a little bit when you've got all of the different stakeholders making law. Um, I think when you're trying to look at everyone's different interests, I think if you look at that's where you go back to like evidence-based medicine, where you're looking at the published literature and you can evaluate the published literature well, which we all need to be able to do because so many different people are trying to get literature published and in different ways now with the internet and everything. That you just have to be able to analyze the literature. You need to be and to understand where certain regulatory decisions come from, and understand, like, let's say we have an employer who thinks they have a very safe workplace. They want to show it off to us. And we go in and we're like, oh my gosh, you need to change this, and this. They're like, right now, these are violations. These are horrible. And then they're like, well, we're just going to go with a different insurance company. What we would say is, okay, we don't want to work with you, right? Like we're not just going to pick up any employer. We want an employer who wants to be a safe work environment and who will take people back with restricted duty and who understand the value of being at work from a social connection perspective, from a financial health perspective, from a community involvement perspective. If you think about like those pillars of lifestyle medicine, and it's not just physical, mental, emotional, you've got the social, you've got the financial, you've got the community, you've got all these different areas that have to be paid attention to, and the concept of also being um, involved in your own health journey. So like I wear a Fitbit, right? I'm supposed to have at least 7,000 steps on this thing every day. And yeah, that makes sense. I should have 7,000 steps. I shouldn't be sitting down. That's not healthy all day long, right? So how can how can I always ensure that this happens? I can't, but I can certainly try with every case I touch, with every policy I make, with every regulation that comes by my desk, and say, okay, what does this mean to us? And make sure I respect it because I respect our laws, but also understand it for what it is and still keep people safe at work.
Got it. That's very
Yeah.
inspirational. And adding those, I only thought that lifestyle medicine was those four core aspects. So I'm learning so much and taking so many notes as well. Um,
Good.
how do you like you touched a little bit about like the legal aspects. Like how do you stay updated on the changing regulations in occupational health and safety?
So we're very lucky at Zenith. We have an in-house attorney who stays on top of all the regulation. And if we have a concern about something, we can comment. There are public comment periods, just like the federal legislation will do public comment. We'll submit public comments to that too. We also have, it's a huge team I get to work with. And it's so important to be able to collaborate with the right people. So we have not only the claims examiner when we talk about cases, but we have a lawyer, we have the doctor, we have a nurse, we have safety and health, we have a special investigations person. Like we have all these people coming together to say, you know, is this ours to own? Oh yeah, this is ours. And where are we going to send them? And what are we expecting? And do we think this is going to go? Right. And then building my team, you have to build a team. If you get the opportunity and the luxury of building a team, I highly recommend you identify your own weaknesses and build it around those with those people who have the strengths where you have your weaknesses. So for instance, um, I I did not expect Dr. Searcy to pass away. And I needed somebody who understood California. I needed somebody who understood the regulations, the laws. And so enter our California medical director, Dr. Rupali Das. Like, Dr. Das is amazing. She is such an asset. Her strengths are so different than mine in many ways. And that's why we're a good team. That's why she was the right person to add to the team. And that's just one of many on the team. You know, we have an orthopedic surgeon, a spinal surgeon, physical medicine and rehab, toxicologist. I already mentioned the pharmacist. And so again, understanding what everybody's strengths are, what your strengths are, and what your weaknesses are is really critical. And building a team that is able to be supportive and collaborative and in itself, a powerful unit, if you will, to make the right decisions.
That's amazing. That sounds like a true words from a leader. Like a true leaders empower more leaders and not followers. So finding people who share, who have you have identified your own blind spots. So you have people
Yeah.
who will, come at those blind spots that you don't stay blind to them anymore. That's amazing and very inspirational. Since you have so many teams, as a chief medical officer, what is your typical day-to-day like? Like, is it meetings, inspections? That's what we're also curious about.
Yeah, so like this past week, I did create some policy, some overarching policy. Um, I have meetings with all of my direct reports on the team to stay on top of everything that's going on. Um, I meet with bill review, the head of bill review every week to identify like, are there any kind of trends that we're seeing, like upcharging for certain things, or because that happens. Like I said, there are a lot of profit motivators in the system, and it may not be from the physician side, it could be from a vendor side, it could be um it could be from lots of different places. And so identifying what new issues might be existing, what might exist, and how we're going to tackle them, approach them, or are they okay, right? Evaluating it. Like there was this one doctor in one state that charged a huge amount of money for a surgery, and they were questioning it. And I looked at the surgery and I was like, this was like 10 hours. This was multi-level fusion. Like I understand why they're charging so much. This was extensive. Yes, they needed the three people who did it, right? And so having we don't automatically say, oh my gosh, that's bad. We say, okay, what is this? What are we looking at? Does this make sense? I went to see a patient in the hospital. I went to see a doctor. I spoke to a different chief medical officer out of a big group in California to try to have them see our patients because of our access to care issues. They don't do comp. I'm like, I don't need you to do comp, just work with Zenith. Like, let's work together. Um, I have a mentee and I had some time with my mentee. Um, I had 15 of my kids' friends over for New Year's, managed that. um, let's see. A lot of staffing, so case discussions, and also I have some people management issues, right? Like you have to manage who's working, especially around holiday time. Do we have enough people working? We had someone pass away recently unexpectedly, which was very sad. And so helping people through that. So lots of different hats every day. Yeah, so it's a lot of meetings. I work remotely from my house, but as I've said, I will go out to employers. I will fly wherever I need to go for patients. I will fly wherever I need to go to meet with doctors. I also created a presentation for an employer group to help their supervisors better recognize when someone might need help. And it could be from a physical perspective or mental, financial, all of those pillars that we talked about. Um, yeah, so lots of different things every week.
Thank you. Sorry, I thought I was muted. Thank you, Dr. Rosenthal. Um,
Yeah.
I'm sort of trying to combine two questions into one, so it might not sound because I'm trying to ask two at the same time, and you'll notice. But how has the pandemic kind of changed the landscape of occupational medicine, specifically in like managing workplace infections?
Well, I think people are actually better, more willing to wash their hands, more willing to wear PPE, personal protective equipment. People have an increased awareness of the value of that after the pandemic, which is good, and aren't just poo-pooing it when we say, you should really make sure that you wash your hands, that you should stay healthy, that you should do your preventive exams. We have a lot more requests for lectures and educational pieces for our insureds on living healthy and being well, on presenteeism and absenteeism, which costs our economy a great deal of money, right? So absenteeism is one thing where people just aren't at work. Presenteeism is more costly. Presenteeism is where you're at work, but you're not quite yourself, right? Like you're there, but you shouldn't be. And there's this great slide I have somewhere where it's like this great image of what exactly like presenteeism. It's like the car mechanic who's just like slumped over, just like next to the car, right? He shouldn't be there. And you put other people at risk, if it's active or just not full attention, and then you're at risk of causing or being injured. And so there's been a lot more attention to that. I think the burnout of physicians and clinicians, we felt that a lot. The hospitals buying up the practices we've seen since the pandemic. I don't know if that's exactly directly a result of that. It might be. I'm not sure. Or if people like saw the importance and the value and the profitability perhaps of being involved in healthcare because you always need healthcare. Um, um, and it's this access issue. This access to care issue has gotten so much worse. I mean, if you think about it from a group health perspective, the time to see a derm, the time to see a specialist, the time to see even your primary, to get my annual mammogram, it's extended. Like you have to be diligent about making your appointments as early as possible because it might take months longer than it used to get care. I think I saw a billboard yesterday. I was going down to a hospital in Miami, and I saw a billboard that was like, you'll be able to see your doctor within 2 days. I'm like, 2 days? Like, well, what if I need you today because of that? And so then you end up with a lot of people going to urgent cares that are not OCMED focused, or you end up with people going to like really like the quickie care places, and they don't necessarily understand the nuances of comp. And so that's changed. People just to be able to get any care. We thought telemedicine would take off a little bit more. We expected it to be a bigger presence in occupational medicine. It it hasn't really been what I thought it would be. There are some docs who continue to see people by telemedicine. And it's actually turned into something where we're like, wait a second, that's a red flag, because they're saying that they examine them and the range of motion is normal and it's an orthopedic exam. Why are they not seeing them? I think it did change the landscape of psychiatry and psychology and opened up people's awareness of mental health issues. And that has become, that is beautiful, right? And that is wonderful. And there's access to telepsychiatry, telepsychology. That's been great. And so that has changed the landscape within, that's a change in the landscape since the pandemic that we've benefited from as a country and as a system, to have access to that. Yeah, those are the biggies that I can think of.
Thank you. And now these are our last two questions, sort of our closing questions. How do you envision the role of occupational medicine evolving in the next 10 to 20 years?
So that is a question that I actually think about a lot, and I think I have to cut it down to like 5 years. Things change so rapidly. So I think you're going to, unless we get people in the pipeline, unfortunately, I worry about the field. Full transparency, I worry about our field. I worry that we don't, people aren't aware enough of the field. People aren't going into it because they don't know about it. That's why I wanted to be here today. That's why when Dr. Clarence sent the email, I was like, yes, I want to talk to people. I want to talk to med students. I want to talk to anybody who'll listen about our, I think that we're going to see a lot of technology and AI being used to do some things that doctors and nurses do today that might make sense for AI to be used, to help. So let's say like, you have like an X-ray and it can read the report, and immediately identify there's a fracture, and it could maybe alert a nurse or alert somebody like there's an acute problem. We need to get this person seen right away. So it should make the process more efficient. I think the process will be more efficient. I think the whole delays in care should go down, but for the access issue. So it shouldn't be like a paperwork issue. That stuff should become seamless, I think, with the electronic health record. And if we could incorporate like formularies and we could incorporate guidelines even into that, to help people. It doesn't mean you have to follow it. Again, you don't have to follow the guideline if that individual is unique, if that individual has a specific situation that doesn't apply, but it could help the process to just make things to make things a little bit more efficient, to use um, data differently than we are today. And I think that we should be able to see that. We will see that in the next 2 to 5 years. And as far as 10 to 20 years, well, in my ideal world, we teach everybody about occupational medicine. We have tons of people who want to go, and we have understand the nuances, who get everything, who are workforce healthy, and stay healthy and well and prevent injuries. I think injury prevention will also be assisted by technology, even more so than it is today. But we have so many people in the field that we can stay healthy as an economy. If we don't have enough occupational medicine physicians and clinicians who truly understand, I actually think not only will we not be as healthy physically and mentally as a nation, I think financially we're going to be unhealthy as well.
Thank
So.
you so much, Dr. Rosenthal. That is amazing to think of. And also thank you for saying the 5 year. I think that's the first time we had a physician kind of say like, because this is such an evolving field, and especially with the rise of AI, there might be jobs in 5 years that, weren't here, today. So thank
Right.
you so much. I appreciate that.
Yeah.
And for our last question, what advice would you give someone, a med student or a pre-med student, considering a career in occupational medicine? What should they do? Who should they reach out to, etc.?
Well, you can definitely reach out to me. Happy to always talk to med students about it. My email is jillrosenthal1923@gmail.com anytime. Happy to talk to any med student interested in the field. We also have a whole ambassador program through the American College of Occupational Environmental Medicine. You can reach out through ACOM. But I think that you should do rotations in orthopedics. Ortho is huge. Ortho is huge in this. Internal medicine, orthopedics. Those are the two biggies, I would think. If you're interested more in the environmental side, the tox side, then of course toxicology, cardiology, pulmonology, dermatology. Um, but orthopedics is just such a huge part of this. PM&R, orthopedics, and I would say attend our occupational health conference, talk to all the doctors in occupational medicine, reach out to us, express your interest. You could rotate as a med student. I'm sure we could create a rotation from my side of the, or if you wanted to spend some time shadowing, because we got the organizations to just to do the right contracts, because we have residents now. We have residents from Loma Linda, UCSF, University of South Florida, and UC Irvine who rotate with us and shadow us. So I would love it if a med student wanted to do that, if they're interested in occupational medicine. But from a clinical perspective, you want clinical, right? Like you definitely need clinical exposure. You need to have as much musculoskeletal knowledge as possible. Most of the injuries we see are musculoskeletal.
Got it. Thank you so much.
Yeah. And to the prior question about where I think about it, like robotic surgery didn't exist when I was in med school. Now you have residents who are apparently only learning robotics to do like a hernia repair, which I remember doing that just my first week of general surgery. They're like, here, this is how you do it. And now they're doing robots. I don't know if a robot is necessary for hernias, but my understanding is that they have surgeons do that so that they can actually learn how to use the robot for the structures where it does make sense, like the pancreas or things like that. So, yeah. Yeah. And another thing that I do in my job is consult for our group health program, our wellness plan, our own internal workers' comp. So, I mean, just so many different things that you can make this be really whatever you want it to be, which is part of what I love about the field. You can make Ahmed your own version.
Thank you, Dr. Rosen. I feel like your love for the field is contagious. So no pun
I hope
intended.
so. I hope
No, thank you
so.
so much
Yeah,
for
I'm so
sharing.
grateful.
Thank you so much for the
Yeah,
opportunity to learn from you and this was an incredibly informative session. I'd love everyone to please give a warm thank you to Dr. Rosenthal in the chat box, please. This was amazing. I learned so much. Thank you so much for sitting down with us on a Saturday morning, first week of New Year's. So thank you so, so much. I
my
really, really
pleasure.
appreciate it. All right,
Thank
now
you.
we talking about like our closing session with our quiz and future session dates. So the link to the quiz for the session is now live on our website at teleshadowing.com/certification. As always, students will need a 70% or higher to pass and receive certification in the session. And we'll also be sending out an email with what Dr. Clarence said in the chat box about conferences upcoming with the American College of Occupational and Environmental medicine, especially with the website that she linked. I'll be sharing that as well in our listserv. We'll send to about 6,000 or 7,000 students. So hopefully that you'll all check it out when we send it out in our email. Thank you so much, everyone, for attending today's session. And we wish you a wonderful rest of your day. Looking forward to seeing you next Friday, January 10th at 11 a.m. EST.